Hi, good evening everyone. Thanks to my colleagues, Dr. Kirthivasan and Intas for this opportunity. Orthogeriatrics is not a new term. It has been in vogue for the past 25 years or so, but fairly new recent in India. Why it is very relevant at this point of time is we are seeing a significantly increase in the number of elderly patients with the fragility fractures and the complications associated with this fracture in our orthopedic practice. So we started this department of orthogeriatrics, first of its kind in India in Kauvery Hospital, Chennai, in June 2015. It combines the medical specialties of orthopedic as well as the geriatric medicine to provide a holistic care with the infrastructure, the medical management, combined with the post-discharge the care for the patients. So the orthogeriatric team comprises of orthopedic surgeons, the geriatric physicians who are specialists in the elderly geriatric care, the anesthetist, critical care physician, the nurses who are specialists in the geriatric care, the geriatric physiotherapist and geriatric occupational therapist. What made us to start this department? I practiced for 15 years in UK and Ireland, where I started my practice in Ireland in 1995, and the population demography was already skewed more towards the geriatric population at that point of time. So we in a trauma department where I worked in Belfast, in a single day I used to see 20 to 25 patients with the hip fractures in elderly, the fragility fractures. So the orthogeriatric department was well developed even at that point of time. And we are seeing in India as well as the population ages, we are seeing a number of patients who live beyond 80, 90 years coming with the hip fractures and with this attendant risk and the complications. So when I returned back and started this Kauvery Hospital in Chennai in 2010, we conceptualized this orthogeriatric department, and we started this department in 2015 in Chennai Kauvery Hospital. Increasing geriatric population. The geriatric problem is not going to be exclusive to the Western and only the developed countries, but as the projection says, by the year 2050, more than 50% of the senior citizens or more than 50% of the geriatric population will live in developing countries like India and China alone. So we are going to see a significant increase in the people in the senior citizens age group and with the resultant problems as well. There's no doubt there's a higher morbidity and mortality after fragility fractures or other porotic fractures in this population. And also, once somebody has a fragility fracture, there is a higher chance that they will have another fragility fracture, if not in immediate future or in later times. So the fragility fractures management is, though the basic principles remain the same, this poses a different kind of challenge in terms of quality of the bone and its ability of the fracture to heal, and also the implant considerations. That's why the orthogeriatric department has got a special relevance in this current day and age. So morbidity and mortality after fragility fracture. If you see this slide, after an elderly patient with an osteoporotic fracture, if you take from the right hand corner the death irrespective of the best of the treatment you offer, the early fixation, the early mobilization, within 3 months nearly 12% of the people will die, and it goes up to 21% within the first year. This is irrespective of the best management. Then if you say that how much percentage of the people will be able to walk without support and going back to the active lifestyle, it's less than 3% only after 12 months. So it produces a significant burden on the hospitals, the caregivers and the society in general. So the morbidity and mortality after fragility fracture continues to remain high. This is a very important one because how much percentage of the people return back to their independence and autonomy in their activities of the daily living. If you look at that bar on the black is post the fracture stabilization, and the gray one is the pre-fracture. So the very few people return back to this autonomy and independence after this fragility fractures. This is irrespective of the best treatment being offered. So the special considerations in this geriatric population, most of them will have comorbidities with the hypertension being the highest one, and the osteoporotic bone, particularly more so in women, the postmenopausal age group, and their immunity will be compromised because of the various comorbidities like diabetes, and also because of the poor muscle strength, they recover very slow after hip fracture fixation. The prevalence of comorbidities in the hip fracture. You see this hypertension is one of the commonest comorbidity, followed by anemias, fluid and electrolyte disorders, pulmonary disease, and diabetes and so on. So when we set up the department, to set up the guidelines for our department, we adapted the blue book, which was brought out by the British Orthopedic Association, which defined the standards for this orthogeriatric department. So all patients with a hip fracture will be admitted to the orthopedic ward within 4 hours of presentation. All patients with hip fracture who are medically fit should have surgery within 48 hours during the normal working hours. Why this 48 hours? I remember when I was working in the UK, if we don't operate on a patient with a hip fracture, fragility fracture within 48 hours, we need to fill out a form which was directly linked to the Department of Health website, justifying the reasons why we have not done the surgery within 48 hours of admission. All the hip fractures patients will be capped so that they minimizing the risk of the pressure ulcer, and all the patients presenting with the fragility fracture should have an access to the orthogeriatric physician and medical management, and all the patients with the fragility fractures should be started on osteoporosis medication management, and all these patients will undergo multidisciplinary approach to prevent the further risk of falls. These are the 6 parameters we adopted from the Blue Book by the British Orthopedic Association to set a benchmark of our clinical care. So the essential steps in the emergency management: as soon as the patient, elderly patient with a hip fracture presents to the ER department, we should not delay in any admission process. Many times they get stuck in the emergency department with irrelevant and unnecessary investigations, sometimes even MRI scan and all. No, they should be undergo a quick evaluation, and they should be admitted in the orthogeriatric department at the shortest possible time. And adequate pain control is the key, because these elderly patients with a lot of pain, it will lead to mental confusion. And the bladder catheterization should be done in all female patients, and also the male patients with incontinent bladder and altered consciousness. They should be screened for urinary tract infection, because that can further lead to mental confusion. They all should be well hydrated. And the preoperative optimization, and most of the time if you see this, the patient is at his best at the time of injury. Whatever you do after that is unlikely to improve his medical condition significantly. That's why we say that try to surgically stabilize them within 48 hours. Anyway, with the preoperative optimization, we have to assess the cognitive dysfunction, if there are electrolyte imbalances which needs to be corrected, if there's a coagulopathy disorder, this needs to be addressed. Also, we should get a cardiologist review to optimize the cardiac function, and also the medications. And many times these elderly people are on multiple medications, so the polypharmacy. So we should optimize the medications and giving them the only minimum which is needed. So the non-operative versus operative management. In India particularly, we see a problem many times. Even if the patient is willing for surgery, the patient's sons and daughters, they will say that no, my mom or dad won't cope up with surgery, so we will manage without the surgery. So it become our duty to explain to them why the surgery is very important. At this day and age, I don't think we should be talking about the non-operative management at all, because there's a significant mortality associated with the non-operative management within the first 1 month after this fracture. So we do spend some time in explaining to the patient's relatives that even if the surgical risk is very high, the surgical management is the gold standard treatment in this elderly patients with the fragility fractures. The timing of the surgery, time and again the evidence is keeps coming back saying that we should operate on them less than 48 hours, unless otherwise there's a medical condition which can be reversed with a prolonged medical management. And there is 48 hours, but preferably even within less than 24 hours is even better. We always have problems with anesthetists saying that patient is on aspirin and clopidogrel, so we should postpone the surgery for 4 to 5 days. That battle keeps continuing, but I keep insisting on to my anesthetist that however there is a limited evidence, there isn't a good evidence to support that even patients with aspirin and clopidogrel can be operated early. But this will go on for some more time until the anesthetists get convinced that by operating early, we are helping the patients to recover faster. How to avoid delay? Within 1 hour of the admission, our patients are seen by the geriatric physician as well as by the anesthetist, and we agree on a treatment optimization plan and schedule the patient for surgery. The next available list, the first patient in the morning list. Please don't leave these surgeries for out of hours trauma list. these patients need extra care, they should be first on the list, on the next day preferably. The surgical considerations, the operative technique, it is definitely far more challenging than operating on a young 30 or 35-year-old patients with a similar kind of fractures. If it is an intracapsular fractures, we go for normally a hemiarthroplasty or a total hip replacement, and if it is an extracapsular intertrochanter fracture, we go ahead with the fixation, preferably with the proximal femoral nail or the dynamic hip screw. So total hip replacement versus a hemiarthroplasty in a fractured hip in elderly people. Previously, there was a concern about doing a total hip replacement in these patients because of the higher incidence of complication like a dislocation, but our technique and implants have far significantly improved, and total hip replacement provides superior outcome when compared with hemiarthroplasty, particularly in people who are less than 80 years of age and who has got more than 4 years of life expectancy. Whereas people more than 80 years and then less than 4 years of life expectancy, a hemiarthroplasty gives good results as well. Cemented versus uncemented. For a quicker surgery, many surgeons used to prefer uncemented hemi or total hip replacement, but the uncemented the hip replacement has got its own challenges with the patients presenting back with the thigh pain and the intraoperative and postoperative periprosthetic fracture. So our preference and the evidence is also more in favor of cemented hip replacement or hemiarthroplasty in these patients with intracapsular fracture neck of femur. Many times these people the patients have got illnesses like Parkinsonism and the stroke, neuromuscular disorders. To prevent the risk of dislocation, we use a dual mobility, the hip replacement with the cup, which reduces the chances of dislocation. And if it is extracapsular trochanteric fractures, we fix it with dynamic hip screw or proximal femoral nailing. Because of the poor quality of the bone, sometimes the implant can fail before the fracture heals. And one thing we have to understand is all these people have got only one chance with for surgery. You do a good surgery, they recover very well. For some reasons, if the surgery leads to complications, they don't do that well after their second fracture surgery. So we try to get the best of the implants possible. Now we get this augmented, cement augmented fracture fixation devices or the special interlocking screw fixation in the proximal femoral nail. With this, we minimize the complications like the screw cutout or the implant failure. Sometimes even in extracapsular fractures, we do hemiarthroplasty if the fracture is severely communicated or if the patient has got already an evidence of degenerative arthritis and if the bone is severely osteoporotic, which will compromise on the internal fixation, or a failed internal fixation also can be considered for hemiarthroplasty or total hip replacement. The postoperative care is the fundamental in restoring the pre-injury level of mobility in these patients. Early mobilizations. Many times I see orthopods saying to the patients or the therapists because of not so good fixation or various reasons, they say non-weight bearing mobilization. A 80-year-old is not going to mobilize if you say that you should not put weight on the affected hip. They all should be aggressively mobilized very early, preferably the same day or the next day after the surgery. This minimizes the hospital complications like the DVT and the pulmonary atelectasis and all. So our dietitian is very actively involved in the management of them, as well as the urologist and the continence care. But one of the things which has improved outcome in our patient is we have got an extensive rehabilitation program which is planned at the time of surgery itself about how they are going to manage at home. This post-op rehab program is well established in the Western world. In our hospital, we have got a rehab center, which is a 30-bedded rehab center for this elderly patients. If they can go to the rehab, or if the patients want to go home with the adequate support, we have got an extended home care. Nowadays, these patients don't come back to us for the stitch removal or catheter removal or dressing change. All this thing is provided by our extended home care delivery team, which does regular periodic monitoring. Our physiotherapists visit them every day at home, and our nurses go ahead with the dressing and removal of stitches. They come back with a video call so that we monitor them mobilizing at home, and the next visit to the hospital may be only after 3 to 6 months time when they are up and mobilizing fully well with for a check x-ray. So most of these patients get discharged on the 4th or 5th day after surgery, but our care doesn't stop at the hospital. It extends to home. That has significantly improved the outcome of these patients. But one important thing is many times as orthopedic surgeons, we don't focus on the osteoporosis management. Because we work very closely with the geriatric physicians, we evaluate them for osteoporosis And all these patients get this vitamin D 6 lakh units during the in-hospital admission itself, followed by the management with biphosphonates or teriparatide, vitamin D and calcium. And false prevention, as I said earlier, these patients are prone to develop another fragility fractures because of the fall, and these patients attend the falls prevention clinic by education, exercises, and the modification, eye care, as well as addressing of the foot problems, and also the walking aid modification. Important thing is home modifications. Our occupational therapy team visits them and ensure that they have got a non-slippery floor, and as well as the railings on the staircases with enough lighting. So all these things are come under the falls prevention clinic with the help of the geriatric physician as well as the neurologist. We run this clinic very effectively. Thank you. Thanks again for everyone for giving this opportunity and listening to me. Thank you.